Ceftriaxone is a third-generation cephalosporin commonly used in the treatment of infections in infants, children, and adults due to its broad spectrum of antibacterial activity, a long plasma half-life, and the ability to penetrate the blood-brain barrier. I'm Dr. Susanna Franco. I'm a neonatal and pediatric clinical pharmacist, and I love researching and teaching complex pharmacology concepts to all levels of learners. And in this video, I'll teach you why ceftriaxone is relatively contraindicated in neonates, and in which patients you could consider using it. If you've spent any time in a neonatal ICU, you've likely learned that ceftriaxone administration is contraindicated in the first 28 days of life. Let's discuss the rationale and evidence for this common claim. First, why is this important to discuss? While not first-line empiric therapy for neonatal sepsis, cephalosporins have been utilized since the 1990s due to concerns for E. coli resistance to ampicillin and in place of gentamicin in neonates with suspected meningitis, acute kidney injury, or gentamicin-induced nephrotoxicity. Specifically, cefotaxime was a standard third-generation cephalosporin for neonatal infections in the US until its shortage in 2015 and subsequent discontinuation in 2018. Some hospitals have been able to continue stocking cefotaxime through its Canadian supplier and affiliated US distributors, but today only one distributor remains. Ceftriaxone is used instead in all older age groups, that is, patients greater than 28 days of life, and is the only therapeutically equivalent cephalosporin to cefotaxime. The American Academy of Pediatrics suggested during the initial shortage that ceftazidime be used in place of cefotaxime, but ceftazidime is actually not a great alternative, as it lacks the gram-positive coverage and CNS penetration of cefotaxime. The history of ceftriaxone's contraindication in neonates is brief. In 2007, the FDA published a safety alert warning that patients of any age should not receive ceftriaxone and calcium-containing fluids within 48 hours of each other. This alert was based on post-marketing reports of 8 neonatal and infant deaths and the discovery of crystalline material in the pulmonary or renal vasculature in 3 of these cases. In 2009, the alert was modified based on in vitro data provided by the original manufacturer of ceftriaxone, Roche Pharmaceuticals, to state that ceftriaxone and calcium-containing fluids may be administered in succession if lines are flushed between administration. Today, ceftriaxone is relatively contraindicated in preterm neonates up to 41 weeks post-menstrual age, and in term neonates up to 28 days of life, receiving calcium-containing fluids or with hyperbilirubinemia. Ceftriaxone's unique pharmacokinetic properties that allow for long dosing intervals and the avoidance of dose adjustments based on renal function differentiate it from other cephalosporins and provide the reason for its relative contraindication in neonates. Ceftriaxone is 85 to 95% protein bound and thus competes with unconjugated bilirubin for albumin binding, displacing bilirubin and increasing levels of free bilirubin in the plasma. Additionally, 40 to 45% is excreted unmetabolized by the gallbladder into the bile. In patients with renal dysfunction, ceftriaxone is excreted into the bile to an even higher extent. Concentrations of ceftriaxone in the bile can reach up to 150 times that of the serum. Additionally, the bile has a relatively high concentration of ionized calcium. Ceftriaxone is highly soluble as a sodium salt, which is why it's manufactured as ceftriaxone sodium. But it is far less soluble as a calcium salt. Thus, in the presence of high levels of free calcium in the bile, Ceftriaxone and calcium can form insoluble salts, or precipitates. This contributes to biliary sludge and can eventually progress to pseudolithiasis, which is essentially ceftriaxone calcium stones. This is the same process that occurs with ceftriaxone and bilirubin precipitation. Bilirubin is lipophilic, and so it must be bound to albumin to travel through the bloodstream. Bound to albumin, bilirubin is not free to cross the blood-brain barrier. Because ceftriaxone is highly protein-bound, it can displace unconjugated bilirubin from albumin binding sites, increasing the serum concentration of free bilirubin available to cross the blood-brain barrier. Theoretically, this could cause kernicterus, or bilirubin encephalopathy, which can include cerebral palsy and hearing loss. However, unconjugated bilirubin levels would have to reach over 25 milligrams per deciliter in the blood to potentially cause kernicterus. There is no evidence that ceftriaxone administration increases unconjugated bilirubin levels to this extent. And ceftriaxone-associated kernicterus has never been reported in a neonate. There are some case reports of bilirubin encephalopathy in older adults with renal failure. So let's discuss the adverse effect that is reported: ceftriaxone-associated biliary pseudolithiasis. There are reports of ceftriaxone-associated biliary pseudolithiasis since 1986 in adults and since 1988 in children. The incidence in children is higher than in adults, ranging in the literature from 17 to 56%. But ceftriaxone is commonly used in these age groups despite this high risk. This is because ceftriaxone-associated biliary sludge is usually asymptomatic and self-resolving, and pseudolithiasis similarly also self-resolves over days or months following treatment. A prospective study in children greater than 2 months of age found that the incidence of biliary sludge and pseudolithiasis with ceftriaxone was 21%. All cases were asymptomatic and uncomplicated. Interestingly, children over 4.5 years old were at the highest risk of developing pseudolithiasis, or sludge, and this has been echoed by other reports. Risk of biliary pseudolithiasis is thought to be even higher in neonates, who have decreased enteral nutrition, decreased bile excretion, decreased renal function, hypoalbuminemia, and are receiving calcium-containing parenteral nutrition or fluids. A systematic review of 25 pediatric case reports between 1980 and 2019 found only one neonatal case of ceftriaxone-associated pseudolithiasis. The patient was a 28-day-old infant with an epidural hematoma who received 3 days of ceftriaxone 100 milligrams per kilogram intravenously. The case was asymptomatic and resolved after cessation of therapy and administration of ursodiol. In general, data suffer from low external validity, inconsistent outcome measures, a lack of comparators, and small sample sizes made up of homogeneous and low-risk neonates. Unfortunately, there are no new data for neonates in the US since the FDA's original safety alert in 2007. A few small studies from about 25 years ago assessing the biliary effects of ceftriaxone on neonates illustrate potential candidates for ceftriaxone use when cefotaxime is indicated but unavailable, and other alternatives are not appropriate or preferred. Hyperbilirubinemia is strongly associated with morbidity in low birth weight, high-risk preterm neonates, and so ceftriaxone should not be considered in any infant at risk of developing kernicterus. At-risk neonates would include those with cholestasis, conjugated or direct bilirubin greater than 2, or unconjugated or indirect bilirubin greater than 8 milligrams per deciliter. Neonates who have received calcium-containing fluids in the last 48 hours are also considered at high risk of ceftriaxone-associated adverse outcomes. And this recommendation is based on data collected over almost 15 years in patients less than 1 year of age. Researchers explored the timing of calcium-containing fluids and ceftriaxone administration, of which almost 80,000 were neonates. The administration of ceftriaxone and calcium within 48 hours of each other was associated with mortality in all infants less than 1 year of age and in the neonatal subgroup. Administration more than 48 hours apart was not associated with mortality. So on a separate note, I would not administer ceftriaxone and calcium within 48 hours of each other in any infant or child with low albumin levels. Despite these risks, intramuscular ceftriaxone remains first-line therapy for the treatment of suspected or confirmed neonatal gonococcal ophthalmia in the US, and monitoring for ceftriaxone-associated biliary pseudolithiasis is not routine. In neonatal sepsis and meningitis management, cephalosporin use is generally not necessary or preferred in place of gentamicin unless we suspect meningitis or the neonate has acute kidney injury or gentamicin-induced nephrotoxicity. In these situations, assuming cefotaxime is not available, I would actually use cefepime instead of ceftriaxone, as cefepime has great CNS penetration and renal dysfunction is a risk factor for ceftriaxone-associated adverse outcomes. Keep in mind that, compared to gentamicin, cephalosporin use increases risk of fungal infection, increases risk of antibiotic resistance, increases risk of anemia, and increases risk of mortality. Also remember that cephalosporins do not have activity against listeria, while gentamicin enhances ampicillin's activity against listeria when co-administered. Taking all of this into account, you could consider using ceftriaxone on a case-by-case basis in low-risk neonates. These would be neonates with no exposure to calcium-containing fluids within 48 hours, who have good renal function, are on full enteral feeds, and have no evidence of hemolytic disease or ABO incompatibility. Monitor bilirubin levels every 8 hours and continue therapy only if direct bilirubin levels remain less than or equal to 2 and indirect bilirubin levels remain less than or equal to 8 milligrams per deciliter. Ceftriaxone should be infused over at least 30 minutes to decrease risk of biliary pseudolithiasis. Perform an ultrasound if biliary complications are suspected at any point during therapy or in the 2 weeks following therapy. Now you know the background of this very famous neonatal drug warning. While ceftriaxone use should generally be avoided, you now have the tools to determine if you could use it safely in situations where gentamicin is not ideal or appropriate. Thanks for watching. All my references can be found in the video description. Please let me know in the comments what topic you'd like me to cover next.